Welcome to the first video for alterations in musculoskeletal function. We will be discussing all kinds of musculoskeletal issues, including trauma, joint replacement, several disease processes, amputation, herniated discs, and several other things. Please take notes while you're watching the video, and they will assist you with your test preparations. When you think about alterations in musculoskeletal function, the first thing that usually comes to our mind is emergent care, broken bones, that kind of thing. Remember that when you're dealing with someone who has that kind of injury, it's considered a traumatic injury, and the pain will be significant, and because of the pain and also because of the pathology, the patient can easily slip into shock. And you know that shock is low blood pressure, perfusion issues, and so forth. So you want to make sure that no matter what the injury is or what the issue is, that you always watch a patient for shock. And then if you find that they are shocky or going into shock, you want to make sure that fluids are on board, that you've placed the patient in a supine position, elevated their legs, and then of course supported whatever injury it is, whether it's a leg or an arm, so that the patient is as comfortable as possible. We're not covering specific traumatic injuries too much in this unit, so I wanted to make sure that you understood the nursing implications for someone who has the typical bone break, crush injury, that kind of thing. First thing we're going to talk about is total joint replacements. These are performed usually electively. Obviously, you don't just go in and say, hey, I want new hips, but when you have a degradation of that joint, then a joint replacement is appropriate. They now replace hips, knees, and shoulders, I believe, and it's not an emergent process, of course. It can be planned. Sometimes it can be planned for years. Joint replacements usually last about 10 years, so they want the patient to be as old as possible and still healthy before they replace them, so that they have them to last longer. One issue that you see in joint replacements is avascular necrosis, where the bone tissue dies as a result of the blood supply being impaired. Not a good thing when you're doing a joint replacement, of course, and then of course the whole hip might be at risk. Very, very rare thing, but can still happen. There are 3 videos here, and I highly suggest that you pause this video and watch these 3. One's on a total hip replacement, a total knee, and then a lower leg amputation. And the reason that I'd like you to watch these surgeries is so that you understand what happens to the body when they're doing the surgery, the positioning that they use, so that you can understand that the pain the patient has is far worse because of the positioning during surgery than just the actual location of the either replacement or injury itself. For those getting joint replacements, they're most often done. Joint replacement is usually done because there's some sort of connective tissue disease where either the cartilage has deteriorated, the ligaments have, and if the patient's had long-term steroid therapy with asthma, that can exacerbate it. It says any synovial joint can be replaced, but for the most part, it is knees, hips, and shoulders that we see. When they do a hip replacement, just think of a ball and socket joint, which is what the hip is, and they put in a 2-piece device that then will behave just like a real hip does. Complications can be hip dislocation, and this can be very serious because if the hip dislocates, they have to go back in quite often to fix it, and of course we don't want to do that. So our nursing implications are what is paramount. We want to ensure abduction. We want to turn and transfer the patient with wedges or abduction pillows, and we want to discourage the patient from sitting for prolonged periods. When they're first post-op, there will be a protocol of how many degrees they can be sitting up. This patient will use a toilet seat that is elevated so that they're not sitting beyond 90 degrees. They're not going to be wanting them to do that for some amount of time. Anytime a joint is replaced, it's called a prosthesis. Again, it's most often done with connective tissue diseases, and the joint replacement itself can be metal, ceramic, plastic, or a combination. Quite often, in my practice, I've seen titanium used the most, and those seem to last the longest. At least that's what the current research says. These slides, this is another slide about the actual replacement, the joint itself. These are very interesting, but remember as you're studying that you want to concentrate a little bit on that and a lot on what's going on with the patient and how you're going to care for them. When there are complications after a total hip replacement, a lot of different things can happen. If there's increased pain, the leg will shorten. If there is a dislodgement of the acetabular cup, which is the actual where the ball and socket meet, and you'll see increased pain, you'll see shortening of the leg, external rotation, and it's the most common complication. And this is where our best nursing judgment comes in. We can avoid this by maintaining abduction, turning and transferring with wedges, discouraging the patient from sitting for a long time. Another complication is skin breaks down on the heel and sacrum if the patient is aging, which most, not usually with a total hip replacement, but with a broken hip they are. They have to move around. We also need to provide prophylactic antibiotics for potential infection. There's nothing worse than a bone infection. In fact, usually people who get an infection in their bone end up dying. Bleeding is a severe Bleeding during surgery is normal. There is a lot of blood. So if bleeding continues, then you have a real problem. And there can be neurovascular compromise. You don't want the patient throwing a clot, anything like that. And then, of course, uncontrolled pain. Whenever there is a broken bone, a bone repair, anything like that, you always risk a thrombus or an embolism. Sometimes it's due to immobility. That's the main reason, as you know from previous courses that we've had. Also, when you're dealing with bones that break or a surgery like this, you always risk a fat embolism. Very rare, but can happen. You have to really assess these patients for DVTs, and you know how to do that, looking for tenderness, redness, and heat. You want to make sure this patient is wearing TED stockings. They'll come out of surgery with them on. Sequential devices, which are, they plug in at the bottom of the bed, and they squeeze the leg to keep those valves moving. You want the patient doing leg exercises, which they don't really want to do post-op, but they need to. And then the patient will be on Lovenox and or Coumadin to make sure that they anticoagulate appropriately to avoid DVT. They won't be on those drugs permanently, but they will be on them for a while. This slide is a very important slide. It has lots of great information. You want the patient to use an abduction pillow. Remember, you know, ad means go towards the body, ab means go away. An abduction pillow basically keeps the leg very straight. It's not kicking it out to the side of the body. It's not crossing the body. It's just keeping it in a straight position. You want to keep the heels off the bed so they don't develop any kind of pressure ulcer. And then check for fever, change in mental status, redness and heat, increased pain. You'll get the patient out of bed as soon as possible and as soon as permitted. Of course, with any kind of surgical procedure, the sooner they ambulate, the better off they do. We also want to prevent orthostatic hypotension. We want to make sure they get enough fluids. They'll be using an incentive spirometer because, of course, they did just have major surgery. Sometimes they get them out of bed the next day, but sometimes if the surgery went well and they're healthy and younger, they'll get them out the same day. You always will get them out of bed towards their good side with the affected extremity supported. You have to make sure that the patient does not twist that surgically repaired leg. And if you have their pain under control, you can rehab much easier and faster. Speaking of pain control, as you know, narcotics have their issues. They can cause addiction if they're taken inappropriately. Constipation, change in level of consciousness, decreased appetite, and orthostatic hypotension. So make sure that narcs are being given adequately but appropriately, and that you're watching for all the signs and symptoms of those issues. How do you educate the patient? This is great information again on this slide. You do not want them to cross their legs. You do not want them to rotate their leg. You don't want them to bring the affected leg past the midline of their body. Don't raise the knee. You want to make sure that there's no real low chairs. They want high-rise toilet seats, which you can buy or rent for when they're home. And you don't want the client to bend more at their waist more than 90 degrees. So you have to give them adaptive devices to put on their socks. You don't want them like pulling their leg up to put their sock on like we do, because that will pop the joint right out of place. So make sure that they are well educated on not bending more than 90 degrees. Total knee replacement has a lot of the same but a little bit different rules to it. The thing about a knee versus a hip is the movement is not as restricted, just because the hip is involved in so many movements where the knee is only involved in the lower leg movement. Knee replacement is the most common replacement, and there's 3 pieces to it. There's the femoral component, the tibial component, and the patella, which is like a fake coin that goes in the front and forms a new patella. They used to do partial knee replacements. I'm not even sure they do them at all anymore because the complications were so rough. They ended up having to redo so many. And so I think they only do total knees now. Complications, same as total hip. They used to use a machine, which is shown here, called continuous passive motion machine. They rarely do these anymore. Now they just get the patient up and moving. Next, let's talk real quick about amputation. This is where they remove part or all of an extremity. It usually happens because of either trauma, so the limb is shot, crushed, broken to the point of no repair, has lost its vascular supply, or it could be because of complications of diabetes. I think that's probably where you'll see most of amputation issues. Occasionally, if a limb is lost due to trauma, if it's sliced off by a machine at work or something like that, sometimes they can reattach it. Or in the case of a thumb, sometimes they can take the toe and replace it. The decision to amputate is not made easily, and they have tried everything to keep the limb before they amputate. There are so many issues involved in an amputation, both physically and psychosocially, that this is not taken lightly at all. Here is some different levels where they amputate, and they do this at these different levels mostly because they're more appropriate for prosthetic devices. For a foot amputation, if they did it right here, the bottom of the foot here, that patient would not be a candidate for a prosthetic. But if they do it up a little bit on the bone, then they can fit a prosthetic device. And that holds true all the way up. They will do an amputation for a lot of different reasons, and we'll get into those on the next video.